and welcome to the medical webinar.
Wait, Doctor. Sekejap. Wait, the last streaming starting. Okay, we have start.
Good afternoon, everyone, and welcome to the medical webinar. My name is Dr. Abinash, and I am an AAIM physician in Taiping, the medical department in Hospital Taiping. On behalf of the College of Physicians, have been organizing this medical webinar. And the purpose is for continuous medical education, empowering doctors' knowledge, and sharing of experiences by the experts. And we are pleased to dedicate this month of October to the endocrinology subspecialty. This month is a bit different because from henceforth, the participants will be viewing this webinar via YouTube. And the advantage is for doctors who are resuscitating patients in the ward, attending to the ill cases, trying to finish off clinics, we hear you, and you can always catch up at your own pace and time. Okay, and without further delay, I will pass this event to our honored chairperson, a very, very dedicated figure in our society, especially the Endocrine Society, Dr. Zanaria Hussein. You're most welcome. Is the head of endocrine subspecialty in the country, and she heads the endocrine unit in Hospital Putrajaya. And in fact, she's so busy that right up to 5 minutes ago, she's still running her clinic, morning clinic. And so we are especially honored to have you today, Dato'.
All right, I guess I'm on air already. Thank you so much, Dr. Abinash, for the introduction, and thank you to the College of Physicians and Hospital Taiping Medical for organizing and for dedicating the month of October for endocrine topics. So it gives me great pleasure to chair the first kickstart, the weekly Thursday afternoon sessions for the medical webinar in endocrinology. I think we have an interesting series of topics to discuss, and the one that we are discussing right now this afternoon is something not uncommon. In fact, something very, very common to all of you there, right across the board, from young house officers to medical officers to specialists, still posing a challenge for us to treat effectively. So I would like to introduce a special person. His name is Dr. Luqman Ibrahim. Some of you will very well know him and have heard him speak. Dr. Luqman is a consultant endocrinologist, and he started his career, in fact, the first decade of career in endocrinology at the University Malaya Medical Center, where he was instrumental in actually getting together the diabetes one-stop center. However, unfortunately or fortunately, look at it in either way, he has left the academia and now has gone down south to my home state of Johor and has so-called open up shop, Luqman.
Another center, another diabetes care unit.
Yes, a Regency Specialist Hospital in JB. So he would be a great asset to them because Dr. Luqman's strength in these recent years is in the area of diabetes technology. He's championed virtual medicine, especially in the COVID era, starting off that service in UM before he left. And he's very much into insulin pumps and even continuous glucose monitoring, which he's avidly doing now. So he has a great interest in type 1 diabetes. Of course, type 2, all of us have to do that as well. So today, Dr. Luqman will actually spend some time giving us updates in the area of diabetes, ketoacidosis, hyperglycemic emergencies, and what is pertinent for us to know at this point in time. So let me invite Dr. Luqman to speak to us, and then invite all of you to convey whatever questions you have following that. All right, Luqman.
Thank you, Dr. Zanaria. So let me share my screen first. And thank you, Abinash, for inviting us to talk on this session today.
You're most welcome.
So for hold on. Okay. So for today's talk, I'm going to talk about updates and controversies in the management of DKA. I will not talk about the usual guidelines on how to manage DKA because I think those would be easily available by now. But I will mention which are the latest guidelines, including the Malaysian one, and then for the listeners and for the audience to refer to later on. Okay. So what are the content of our talk today? I'm going to touch a bit about the use of SGLT2 inhibitors in people with type 1 diabetes and prevention of SGLT2 inhibitor-associated DKA, especially in people with type 1 diabetes and type 2 as well, and using home blood ketone monitoring for DKA prevention. And I will share some data on the use of CGM, pump, as well as hybrid closed-loop system on the risk of DKA. And then I will also cover some topic about some controversial area like the choice of fluids during DKA treatment, use of basal insulin, as well as use of SGLT2 inhibitor in hospitalized patients who are not critically ill. Okay, so why is this a re-emerging topic? Because number one, we all know SGLT2 inhibitor by now. We all know that it's widely used in people with type 2 diabetes. Even people without diabetes also are using it, those with CKD, those with heart failure. So when there are more people who use SGLT2 inhibitors, there are higher risk of euglycemic DKA, and that's why this is a topic that has gained interest in the past few years. Of course, COVID-19 is another big event that reignited the interest on the topic, especially on sick day planning, how to do this remotely, how to manage yourself at home when you are sick. And then last but not least, there are emerging data demonstrating the efficacy of SGLT2 inhibitors in people with type 1 diabetes. And this is hotly debated, especially among the people who want to use this agent for people with type 1 diabetes versus people who wants to play it safe and want to avoid diabetes ketoacidosis in this group. We will go through this data in a while. Okay. So why is there an interest about using SGLT2 inhibitor in people with type 1 diabetes? Because the data is quite clearly supporting its benefit actually. If you look at this first study, this is a pooled data from the DPIC program. The DPIC program is a program that tested dapagliflozin in people with type 1 diabetes. And in this program, in this particular paper, they put DPIC-1 and DPIC-2 data, and then they look at the time in range, time above range, as well as time below range. Yeah, the blue pie here is time in range. The red pie here is time above range, whereas the purple pie is time below range. I want to highlight to the audience or to the listener that if you look at the progression of time in range in the three groups, placebo, dapagliflozin 5 mg, as well as dapagliflozin 10 mg, you will notice that there is an increase of time in range in both groups that receives dapagliflozin from 43 to 51% in the group that receive 5 mg, as well as from 43 to 53% in people who receive 10 mg. Whereas in the placebo, the time in range remains the same, 43 to 43%. At the end of the trial, at week 24, the difference between the placebo and the treatment arm, between placebo and the low dose dapagliflozin is 9%, and between placebo and the high dose dapagliflozin is 10.67%. What I also want to highlight here, an important finding, is the time below range. If you notice that the time below range is almost similar in all the groups. In the placebo group, at the baseline, time below range is 5%. At the end of the trial, time below range is 4.8%. In the low dose DAPA group, time below range 4.96. At the end of the trial, 4.85. In the dapagliflozin 10 mg group, time below range is 5.3%. And at the end of the trial, 5.1%. So there's really hardly any effect on time below range. There's hardly any effect on hypoglycemia, but it clearly shows an improvement in the time above range, time in range, which is reflected by the reduction in time above range as well. In more recent studies, empagliflozin also has been tested in people who use sensor augmented pump. Again, I wanted to bring your attention to the same numbers as well. Time in range has improved, let's say from empagliflozin versus placebo, right? You can see that time in range, the difference between the two treatment arm is 11.4%, and time in tight range, also increased by about 10.9% difference from 33 in the placebo group versus 46.3% in the group that received sensor augmented therapy, pump therapy plus empagliflozin. But importantly, I wanted to highlight the hypoglycemia part. If you notice at time below range, below 3.9 is increased in the empagliflozin group at 4.6% versus 3% in the placebo group. But the significant hypoglycemia below 3.0 is not significantly increased. Both are at 0.65 and 0.61%. So in theory, you will get a major improvement in the time in range, but at a slight increase in the mild risk of mild hypoglycemia, which is between 3.0 to 3.9. Yeah. The same study also look at the effect of empagliflozin in people who use hybrid closed loop system, and they find the same finding that it does increase time in range by a number of 7%. The magnitude of this difference is smaller as compared to sensor augmented pump, because we know how a hybrid closed loop system, it also corrects for hyperglycemia, and hence it attenuates the effect of SGLT2 inhibitor on the time above range. When comparing the time in tight range from 3.9 to 7.8, there's also an improvement. The difference is 9.3% in the placebo group, 44%, whereas in the closed loop, in the empagliflozin group is 53.5%. The difference between hypoglycemia rates in both groups, below 3.9 as well as below 3.0, were not different. They were both equal at 2.5 and 2.1 for the below 3.9, and 0.47 and 0.45 at below less than 3.0%. Yeah, sorry, less than 3.0 millimole. But unfortunately, all current data so far has shown that SGLT2 inhibitor does increase the risk of DKA in people with type 1 diabetes. In the DPIC trial, that shows that the frequency of DKA is 1% and 2% in the treatment arm versus 1% in the placebo arm. In the DPIC2, 2.6 and 2.2 versus 0 in the placebo arm. The DPIC1 and 2 pooled population, 4.0 and 1.1 and 1.1 in the placebo arm. In the in-tandem group that compares sotagliflozin, it was 3% in the treatment arm, and it was 0.6 in the placebo arm. In the EASE program, this uses empagliflozin. The risk of DKA were 4.3, 3.3, as well as 0.8. Okay, and the placebo group is 1.2. So there are clearly an increase in the risk of DKA, and in some instances, you can see that the risk of DKA is also dose dependent. Yeah. So another important thing that was seen during this phase 3 program is that the risk of DKA seems to be lower in people who has a BMI of more than 27. Yeah. So because of that, the EMA initially approved low-dose SGLT2 inhibitor as an adjunct therapy for people with type 1 diabetes when their BMI is more than 27 kg per meter squared. This table is taken from the ADA-EASD guideline on the management of type 1 diabetes in 2021, and it shows the 4 different adjunct therapies that you can consider in people with type 1 diabetes. I also would like to highlight, if you notice that these not all treatments are approved. Even metformin not approved, pramlintide is approved in the US, GLP-1 receptor agonist not approved at the time of writing, and at the time of writing, SGLT2 inhibitor was approved in the Europe. Yeah. If you notice that among all this adjunct therapy also, only SGLT2 inhibitor has been shown to increase the time in range, whereas the data is not yet available for the other treatment options. Okay, so because of the encouraging data, and because of the positive data from the phase 3 trials, and because the known risk of DKA in people with type 1 diabetes who receive SGLT2 inhibitors, in 2019, a group of international experts convened together and reviewed the literature and come up with a consensus paper on how to mitigate the risk of DKA in people with type 1 diabetes who receive SGLT2 inhibitor treatment. So what they recommend is, most importantly, is patient selection. You want to select the appropriate patient to consider for treatment with SGLT2 inhibitor. They divided the risk into moderate or high, low to moderate, and minimal to low. There are some criteria here shown. I won't go through all of this. So for example, if let's say the patient has acute illness or vomiting or excessive alcohol use, so these people will be at high risk of DKA. Whereas if the patient has low BMI, moderate alcohol use, female sex, inconsistent calorie intake, so these people will have some risk, but the risk is quite minimal. Okay, and they would recommend that the best criteria for your patient selection is going to be adult who can adhere to the prescribed diabetes regimen, willing to perform diabetes self-management tasks, regularly perform blood glucose check or uses CGM as prescribed, willing to test for ketone during sick days, receive appropriate education, have access to ketone testing materials, and immediate access to the diabetes care team, does not use alcohol or drugs excessively, does not have impaired cognition, and also not pregnant as well. Okay, and they also recommended some of the risk mitigation strategies that you can consider. For example, like patient education, you want to advise them on how to recognize the symptoms of DKA, how to differentiate between hyperglycemic or euglycemic DKA, and the importance of ketone monitoring as well. They also recommend that not just patients, but clinicians also need to be educated on how to use SGLT2 inhibitor and how to mitigate the risk of DKA in patients who receive SGLT2 inhibitor. So for example, like how to detect euglycemic DKA, how to prevent euglycemic DKA, how to not miss a diagnosis of euglycemic DKA, and then how to treat euglycemic DKA. So basically, they recommend this STITCH protocol: stop SGLT2 inhibitor treatment, insulin administration, carbohydrate consumption, as well as hydration with a suitable drink. And then as well as advice to the regulators and manufacturers about the risk communication, which includes product labeling, healthcare education, as well as medication guide and patient alert card. Okay, I'm going to bring up this interesting study that I have recently heard a few weeks back in AASD. So this, I took this slide from Dr. Hussam Ghanim. He conducted a study to look at the ketogenic and metabolic effect of dapagliflozin, as well as exenatide as part of the study. But really what I am interested in this particular study is the effect of is the ketogenic effect of dapagliflozin, because I've been thinking of, because when we know that SGLT2 inhibitors by its nature is ketogenic, right? And because we also know that SGLT2 inhibitors can cause euglycemic DKA. So the question is, how do we diagnose DKA at home? Do we check blood glucose? Yes, we can check blood glucose, but the problem is SGLT2 inhibitor is known to cause euglycemic DKA. So a normal blood glucose does not exactly rule out DKA. So the question in my mind was that, can we check blood ketone? Would blood ketone be helpful? Knowing that SGLT2 inhibitor themselves are already ketogenic, would it help to still check blood ketone? So what this team did, or what this group did, is that they randomized patients who are on insulin pump to receive either dapagliflozin or Bydureon or placebo or both DAPA and Bydureon. So there are 4 groups. One received placebo, one received dapagliflozin, one received exenatide, and the other one received both dapagliflozin and exenatide. Yeah. And then what the design of the study is quite interesting. So what they did, they asked patient to come fasting, and then when the patient come to the trial or to the trial site, they ask the patient to stop insulin pump for 6 hours and then check the glucose and the ketone at the beginning of the stopping insulin pump, as well as after 6 hours of stopping insulin pump. And then they repeat the same process. After that, they start patient on treatment, either dapagliflozin or exenatide or both or placebo. And then they ask patient to go home. 3 months later, they ask patient to come back and repeat the same process again. So it means they've come fasted at night. And 3 months later, they ask patient to come back again. And then they ask patient to fast at night, as well as they stop the insulin pump in the morning and wait for 6 hours, and then they start back the pump. In the meantime, they check glucose and ketone at the beginning of the stopping, as well as at the end of the stopping period. So first, what did they find? Treatment with SGLT2 inhibitors actually clearly benefits this patient. You will see a HbA1c reduction of 0.3, but importantly, you also see time in normoglycemia or time in range improvement of 14% improvement, and that's quite a lot. Yeah, and there were 11% in the exenatide group, and when you combine both SGLT2 inhibitor and GLP-1RA, you get a improvement in the time in range of 16%. If you look at the time in the hypoglycemia, again, exact similar finding, no difference in patient who receive placebo or patient who receive SGLT2 inhibitor. So what am I interested on is really the ketone part. So if you look at this, actually, in this patient, in the placebo arm, the ketone, when they come fasted at night, right? When they come in the morning, the ketone before the start trial is somewhere between 0.2 to 0.3. And they are all roughly about the same, actually. And after 3 months of treatment, when they come, right, actually the ketone level is still about the same. So even with 3 months of treatment with SGLT2 inhibitor, you can expect a ketone range of maybe about 0.1, at 0.2, at max 0.3 with a combination of biduron or GLP-1RA and SGLT2 inhibitor. So it does tell me that for patients who are treated with SGLT2 inhibitor, you do not expect very high ketone. But so meaning that if you do see high ketone in patients who are treated with SGLT2 inhibitor, this patient is not well. So if let's say you will see a patient who are taking SGLT2 inhibitor and their ketone is 1.5, for example, right? This is not expected with SGLT2 inhibitor, and this indicates that the patient is not well, and this patient needs to take action for sick day treatment so that he or she can prevent the development of a DKA. Okay. Unfortunately, and this is a matter of this is something that was quite hotly debated as well. Just for the background information, just to put it in the context, the FDA has never approved any SGLT2 inhibitor for use in type 1 diabetes, whereas the EMA actually approved dapagliflozin for use in people with type 1 diabetes, with two provision. Number one is the use low dose. Number two is the BMI is above 27. But unfortunately, despite all the positive data that has been emerging in the scientific community, somewhere around October last year, AstraZeneca decided that they wanted to withdraw the indication for dapagliflozin for people with type 1 diabetes. And because of that, technically now, even the whole of Europe, the use of dapagliflozin is off-label. So the EMA recommended that patients who are treated with SGLT2 inhibitor to be withdrawn from SGLT2 inhibitor treatment, and then their insulin dose be readjusted back. But if you look at the data that we have, that I have shown so far, treatment with SGLT2 inhibitor does clearly improve time in range without increasing the risk of hypoglycemia, at least without significantly increasing the risk of hypoglycemia. And this is not something that can easily be achieved in people with type 1 diabetes. So there were quite a lot of call for the regulators and the industry to reconsider this decision. And I think it remains to be seen in the future where this will take us in the future. In the meantime, I can only advise extreme caution when you want to consider the off-label use of SGLT2 inhibitor in people with type 1 diabetes, because there are some clear benefit, but unfortunately, there are no regulatory approval that we can rely on at this point. Okay, so coming to that, the same consensus, the same expert group in 2019, they come up with a recommendation on how to monitor ketone while using SGLT2 inhibitor. And if they say the ketone is less than 0.6, you do not need to take any action. If the ketone is between 0.6 to 1.5 millimole, right, and you want to take 1 to 2 exchange of fast-acting carbohydrate, and then maintain fluid consumption between 1 cup, about 1 cup, 300 to 500 mils every hour, and then administer rapid-acting insulin based on the carbohydrate intake every hour, and check blood ketone every 3 to 4 hours until it resolves. But if the ketone continues to increase from 1.6 to 1.6 to 3.0, the same treatment recommendation applies, but they will ask you to consider seeking immediate medical attention. If the ketone goes above 3, this is already in the DKA range. They advise to go and seek medical attention immediately. In 2020, the NHS also updated their recommendation for sick day plan, but this is more in response to the COVID-19 pandemic, because people are staying at home. So they wanted to make sure that patients have and access to materials that can help them manage sick day at home during the COVID-19 pandemic. There are some slight differences in the NHS recommendation. If you notice that the ketone, they use ketone of 1.5 to 3 millimole, okay, and then they recommend 10% of total daily dose every 2 hours. And if the ketone is more than 3 millimole, they recommend a total daily dose of 20% of total daily dose every 2 hours, plus the usual carbohydrate ratio. And then for people who are injecting subcut insulin or basal insulin, they ask to increase the basal insulin by 10 to 20% or more if the ketone is more than 3 millimole. But if let's say you are on an insulin pump, for example, they recommend you increase this by 25 basal by 25 millimole, 25%. And then if ketone is more, by 3 millimole, they advise to increase by more than 50%. The main difference between this and the previous recommendation that I showed you is that I personally feel that once the ketone is more than 3 millimole, we are treading into danger areas. So I would prefer if the patient just go to the hospital immediately and get treatment immediately. Yes. But I think we can take this into the context that this was written at the time of the COVID pandemic. So that might explain why the threshold for ketone to come to hospital might be different from a pre-pandemic recommendations. Yeah. So having said that, because we try to teach patients how to monitor ketone at home. We try to come up with a 6-day plan on how to monitor ketone at home. But the question is, how do we actually monitor ketone at home? I would like to share my new, not to say my new favorite device, not to say favorite, how I currently now advise patients to check ketone. So for example, if let's say a patient who had a history of recurrent DKA, okay, so when they are discharged from the hospital, I would advise them to consider a CGM. Use a CGM because of a few reasons. Number one, they can monitor their glucose after discharge. Okay. Number two, I will show you some data on the use of CGM and subsequent DKA risk. Number three, if they are using Freestyle Libre, right, they can also buy the ketone strips, which I typically recommend them to go and buy and keep as a standby. If they have at least one DKA in a year, I will tell them to go and buy so that, number one, if let's say they use the ketone strips, okay, if let's say they get another sick day and they need to use a ketone strip, it would probably help them to prevent a DKA, or if they do develop a DKA, it will probably reduce the severity of a DKA. So it's still a money worth spending. If they do not need to use the ketone strip at all, because the ketone strip has quite a short expiry period, about 1 year. So by the time patient bought, it would have spent maybe about a few weeks or months on the shelf. So usually the expiry period would range between about 9 to 10 months. So if let's say they don't use the ketone period at all until expiry, then it's also a good thing because it means that they are not at risk of DKA, or at least their risk of DKA has markedly reduced since the last time they had DKA. So this is my current workflow now for patients with at higher risk of DKA. So what do we know about using sensor or using CGM in patients who are at risk of DKA? This is a registry that was done in Germany, Austria, Switzerland, as well as Luxembourg. And then they pull out patients with type 1 diabetes who were initiated on CGM. And then they look at the risk of they look at the risk of DKA for this patient for the next 12 months, for the next 1 year. And they found that this patient who was started on CGM actually have less risk of DKA in the subsequent 1 year, for the next 1 year. So if you can see here at the baseline, the risk of the percentage of subject with at least one event is reduced from 1 to 0.5%, as well as the number of event is also reduced as well. Number of patients is reduced, and number of event is also reduced from 2.0 to 1.2 to 1.1 events per in that 1 year after initiation of CGM. Yeah. What about insulin pump? What do we know about insulin pump and DKA risk? Should we offer insulin pump to patient after discharge from DKA? Unfortunately, the data is still quite mixed lah. Okay. In this older registry, this was done in 2013. This was from the West Australia Childhood Diabetes Database. They look at patients who were started on insulin pump, and if let's say this patient had DKA hospitalization within 12 months prior to the start of insulin pump, then you actually get a reduction in the DKA risk. If you as compared to placebo or as compared to the matched non-pump cohort where there were actually an increase in the DKA risk. But a more recent registry from Sweden, they found a different distribution of DKA. So this would be the expected distribution. The dark bar is patient who receive injection, and then the gray bar is patient who are on pump. But they noticed that among the patients who are admitted for DKA, right, they will notice that there was a higher group or higher proportion of patients who are using insulin pump. And then when they sub-analyze this data, they notice that this increase in DKA, or this apparent increase in DKA in pump users, are largely attributed to the mild DKA. Yeah, so it means that there's higher risk of mild DKA, whereas when you look at moderate to severe DKA, there's not much difference between the pump and the MDI users. What about hybrid closed loop? Currently, no data. The largest registry by Medtronic, the 780G registry, does not capture DKA data. So we do not know how many patients who use 780G who develop DKA. And currently, all manufacturers recommend reverting the system to an open loop system, means back to manual control during intercurrent illness or during ketosis. So we can't say whether there's any known benefit or not at this particular point. It's still a bit too early. One of the important milestone or update in the DKA management is, of course, our society MEMS, led by Datuk Dr. Zanaria, has come up with an updated guideline on the inpatient glycemic care in 2020, which contains a very well-written chapter on management of DKA in that guideline. So I just take a screenshot of that particular page on the management of DKA. And then in 2021, the JBDS also come up with an update to their own guideline on diabetes ketoacidosis in adults. So I just cover some of the topics that were updated in these new guidelines. So among the topics that they have made new recommendation is that, number one, they recommend measure venous rather than arterial bicarbonate or pH. And then blood ketone meters should be used as a point of care testing during the management of DKA. They recommend sodium chloride solution. This one I will touch a bit on the data so that you can understand what the controversy is about. They recommend sodium chloride as a recommended fluid of choice in the general medical ward. They also recommend that if, let's say, the patient is already on long-acting insulin or NPH or basal insulin, this should be continued during DKA treatment. And insulin should be administered as a fixed rate intravenous insulin infusion calculated based on body weight, as well as they do not recommend the use of priming bolus dose of insulin anymore. So let's talk about the fluid, choice of fluid first. One of the new data that come about was from the Vanderbilt University. They had a very large trial that looked at the use of crystalloid, normal saline versus balanced solution in two settings. One is in critically ill patient, and the other one is a non-critically ill patient who were treated in the emergency department. So in the patient who are critically ill, they found that the use of a balanced solution actually reduces the risk of major adverse kidney outcomes within 30 days. Yeah. And then when they look at the non-critically ill, who are treated in the emergency department, also they find the same finding. There were reduction in the major adverse kidney outcome in the patient who received balanced crystalloid as well. So in 2020, the same group, they look at the sub-analysis of the pooled patient from the SMART trial and also the SALT-ED trial, and they look at patients who actually had DKA at that time. And they look at what's the difference if you treat DKA with normal saline and balanced solution. Is there any difference in terms of outcome or not? What they found is that when you use a balanced solution, the resolution of DKA is faster with a balanced solution. As you can see, the resolution of DKA here in the chart A or in the diagram A, and B is a discontinuation of insulin infusion therapy. Is faster in patients who receive balanced crystalloid. But when you look at the other outcome, like the in-hospital death, ICU admission, hospital-free days to day 28, ICU free days, the kidney outcome, all they actually no difference except for maybe hypokalemia saja. The rest all no difference. So because of that, we know that patients who receive balanced solution, they actually recover from DKA faster. You can stop the insulin infusion faster, but this does not necessarily translate into a meaningful heart outcome. So because of that, the JBDS still recommend normal saline. But if you look at the argument given by JBDS, is mainly because the balanced solution has insufficient potassium if used alone, and is not commercially available as a pre-mixed potassium, and is unfamiliar and not routinely kept on medical ward. Whereas, and this is mainly the reason why they still recommend, they will say that if most of the time we use normal saline, and normal saline is widely available, and a pre-mixed normal saline with potassium is also available from the pharmacy. So this will be a safer fluid to use during a DKA. Yeah. The next thing that I also want to touch a little bit is on the use of early basal insulin during DKA. the JBDS guideline, they recommend that patients who are already on basal insulin should continue their basal insulin during DKA treatment. But if you look at the underlying data, you will see that in this patient, they compare between early and delayed introduction of basal insulin in patients who were treated with DKA. And you will notice that the difference is only on the time of intravenous insulin infusion sahaja. If you look at the rest of the outcome, the length of ICU, the length of hospital stay, the time to end gap closure, they are all exactly the same. There were no difference. So my take on this is that, yes, if let's say your patient has mild DKA, you may consider to continue the subcut insulin. But if your patient or subcut basal insulin on top of the IV insulin, but if let's say if your patient has severe DKA, your patient has multiple organ failure, your patient is in a coma, intubated, and you expect this patient to stay in the ICU for the next, let's say, 1 week, I would say there's really no reason to start that basal insulin so early. Maybe you can consider starting just about before discharge from ICU, so that you would transition easier during that time. Okay, so last section for my lecture today is going to be the use of SGLT2 inhibitors in hospitalized patients. Traditionally, we know that we should avoid SGLT2 inhibitors in hospitalized patients because we know SGLT2 inhibitors by themselves are ketogenic, and acute illness worsens the ketogenesis and precipitates diabetic ketoacidosis. And because of that, even guidelines, they recommend we stop before elective surgery. For example, like the AACE recommends stopping for 24 hours before elective surgery. Some people now, they even recommend 48, 72 hours before elective surgery to reduce the risk of DKA, provided the glucose is manageable during that time. Okay, but for those who are following the data on SGLT2 inhibitor closely, you would be aware that by now there are 2 trials that has looked at the initiation of SGLT2 inhibitors in patients who are hospitalized for heart failure. The first trial is the Soloist WHF trial. In this trial, they started patients on SGLT2 inhibitor either immediately before or immediately after discharge. Yeah, and in this trial, they found that the risk of DKA is actually not increased in patients who receive sotagliflozin, even when you start before discharge. In the newer trial, the EMPULSE trial, this was started early during the hospitalization for heart failure. So it means that even before the patient became hemodynamically stable, or before the fluid balance has been stabilized, they already started the patient on SGLT2 inhibitor, and they did not see any diabetic ketoacidosis in this trial group. But these findings should be taken as a caution, because we know by now that SGLT2 inhibitor has a disease-modifying effect on heart failure. And initiation of SGLT2 inhibitor during heart failure hospitalization most likely modifies the cause of hospitalization for heart failure itself. And the same cannot be said for hospitalizations for other conditions. So for now, it does appear that initiation of SGLT2 inhibitor during acute heart failure hospitalization is safe, but we should probably still avoid for other indications for hospitalization. So in summary, just to recap my lecture so far, number 1, we know that SGLT2 inhibitor in type 1 diabetes improve TIR, time in range, with a marginal increase in the time below range. And in most studies, it doesn't increase hypoglycemia at all. However, unfortunately, the regulatory approval for this indication has been withdrawn, and therefore I would advise extreme caution to use it off-label. Considering the benefit versus the risk, as well as the risk of DKA, you might want to involve a specialist or a consultant in the decision to initiate a patient with type 1 diabetes on SGLT2 inhibitor. Number 2, the guideline for DKA risk mitigation is available, and the important part in the guideline, they emphasize strongly on patient selection and education as the key risk factors to mitigate the risk of diabetic ketoacidosis. Number 3, consider CGM for patients who are at risk of DKA or who are at risk of recurrent DKA. For example, those who are discharged from a hospital with a DKA. Number 1, because many times we know that this patient has poor glycemic control, and the data for improvement in glycemic control with the use of CGM has been well established by now. Number 2, there could be a potential benefit for risk reduction for recurrent DKA for this patient in the future, based on what we know from the registry data. Number 3, depending on the device that you use, you may also be able to use that device for home ketone monitoring and take that opportunity to advise them on a sick day management. The next, normal saline is still a standard use for fluid replacement, but however, data is emerging for the role of balanced solution. And then lastly, SGLT2 inhibitor used for hospitalizations for heart failure has been currently shown to be safe as well as beneficial. But however, if let's say the patient has other conditions that could possibly increase the risk of DKA, for example, they have heart failure and cellulitis, for example, or they have heart failure and pneumonia or other things, then it could be a bit hard to extrapolate this data. You might still want to be cautious and might want to avoid in these people, but use clinical judgment in deciding whether this treatment should benefit or not. Last but not least, thank you. And then I pass the mic back to the chairperson. I hope we can discuss this topic in more in depth during the Q&A session.
Thank you so much, Dr. Lokman. You've really done quite a lot to update us on the recent and current evidence in the areas related to DKA. Some of the unexpected topics that you brought up, but very interesting. So I'm just wanting to know whether there's any questions posed by the audience. Just looking at the chat group, and I don't really see any questions at the moment. But we can certainly have a conversation and wait for the questions to come in. And maybe the coordinator can alert me if there are any questions. So really, oh, okay.
Dr. Zana, there's one question.
Okay, we'll do address the question first. Okay, so yeah, Dr. Lokman, actually, surprisingly nowadays, any lecture on diabetes can't escape the topic of SGLT2 inhibitors, yeah? So you started off with SGLT2 inhibitors and its, possible role in type 1 diabetes, which I think the broad community of endocrinologists and physicians in Malaysia are not really ready anyway to have it there in the treatment of type 1. And then you ended up also with SGLT2 inhibitors and seeing their role using it in an inpatient setting, especially with acute heart failure. So the question that we have from our audience is actually from Hannah Berry. Maybe that's nice name. The question is, when would you restart an SGLT2 inhibitor after an episode of DKA? Do you even restart it, So this is a very pertinent question, because we're going to have, we might be actually learning more about how to avoid DKAs, all these preventive measures that we know now to advise the patients. So unlike the initial years where we kept seeing a lot of admissions for DKA, we might be seeing less now. But it is a drug that is almost always going to be beneficial for our typical type 2 diabetic. So, and a lot of DKAs are in type 2s in Malaysia because our type 1 population is so small. So, Dr. Lokman, could you advise us about this?
Okay.
Yeah.
The reason why I didn't touch, I was thinking about this question also when I prepared the lecture, but the reason why I decided not to touch about this was because there's really no data to show. Okay. The only thing that I have found so far is that in the JPDS guideline, they recommend you consult a senior diabetes team to restart, to decide when or if you should even restart SGLT2 inhibitor after an episode of DKA. But I think there's a lot of things that you need to take into consideration now, because there are clear benefit for SGLT2 inhibitor in people with heart disease, heart failure, CKD as well, and you do not necessarily want to sort of like deprive these people from the benefit of SGLT2 inhibitor. So it's like the question of, do you start ACE inhibitor after an episode of AKI? I think it really boils down to the judgment of the team and the treating doctor on whether the benefit will outweigh the risk. I would imagine once the DKA risk has been deemed to be sufficiently low, so it means that the patient does not have a recurrent DKA, the patient is well educated on how to maneuver themselves during sick days, the patient have access to ketone monitoring, glucose monitoring, as well as emergency services during sick days, maybe it's time for you want to consider starting, especially if the benefit clearly outweighs the risk, like if the patient has CKD, proteinuria, heart failure, maybe those are patients that you might still want to consider. If let's say there are none, for example, maybe it's worth waiting a little bit longer, 1 year longer, before you are very clear that the risk of DKA is clearly low before you restart.
1 year.
What do you think?
Yeah, I mean,
Yeah.
usually the decision to start SGLT2 inhibitor is usually never in an acute
Yeah.
situation, isn't it? It's usually in an outpatient setting for long-term prevention or
No, I
glycemic
mean, sorry,
control.
I'm talking mainly for SGLT2
Yeah.
inhibitor induced DKA. So whether you
Yes,
restart
yes,
or not,
yes,
yeah.
yes, yeah. So as you mentioned, I think the only time that you would really want to think about restarting it in an inpatient setting is it's what you had mentioned in the setting of acute heart failure, kan?
Yep,
So
yep.
I think if the indication is strong, especially the cardiac, renal, then you would eventually want to resume the SGLT2 inhibitor for its benefits. But for glycemic control, maybe you would opt for some other strategy first. Yeah. um, but still, it's always individualized
Yep.
decision, kan? Yeah. Right. There's another question here, and it's a very practical question, which we often, make sure our medical officers are clear about. And it's actually, how do you transition from IV insulin infusion that you start to oh no, this is insulin pump. Sorry, I was thinking about sub-Q insulin. So you have a patient, and this would be in the context of type 1, yeah, because in Malaysia it's type 2s don't be on pump, but type 1s are on pump. So they get a DKA. Do you use the pump while they have DKA, or if you don't use the pump, how you switch them back? So Lokman will know a lot about this. Okay.
Okay. Insulin pump works very fast. It works way faster than like the usual basal insulin that we give. So when you want to restart insulin pump, of course you will start back with the same basal setting as pre DKA setting. And actually, if you just start the pump maybe 1 or 2 hours prior to stopping the IV insulin, that will be plenty enough already actually. For the pump to have enough basal effect to prevent a rebound hyperglycemia. And for subsequent means, the patient can always bolus as per usual, carb count and bolus as per usual. Yeah, but if you, let's say the patient is well from discharge from ICU, you want to restart them a pump a day earlier before, or maybe you tell them, okay, tomorrow we off your IVI, tonight you can start your pump and see how your pump works first. I think that's a perfectly practical approach lah, because patient is already on pump, and in the meantime, overnight the nurse can gradually taper down the IV insulin based on the glucose reading on top of the pump treatment.
Right. Okay. I don't see any more questions yet. So those were the two questions. I'm sure they'll actually forward any other questions if there are. Yeah. So
Oh, by
let's
the
see.
way,
Yeah.
I would like to also add the requirement for pump use in a hospital. The patient must be able to carb count. So it means your patient must be lucid, must be able to operate the pump themselves. You do not restart the pump in patients who are like sick, too tired to carb count, or basically not fully back to their normal self.
Um, Maybe to sort of stir some interest, I'm sure some of the audience are facing the same issue. Is we're seeing a lot of younger diabetics who are obese coming in with DKAs, and a lot of them are during the COVID as well, and they were on a huge amounts of insulin infusion. Yeah, Lokman, I think you may have actually noticed that also, and it goes on for some time before we can get into better control. Is there any review or data out there about how we should approach these group of patients?
I have not personally have not come across any data or any guideline, even guideline to guide on how to maneuver this problem. I have talked to some people, and I've heard people who use gradually increasing the subcut basal doses before they reach a certain acceptable like glucose level to
Yeah.
discontinue the pump. So for example, if let's say your patient is on a like
Medication.
very huge doses, like macam 10 unit, 15
Yes.
units in a day, for
Yes.
example, right? Then you want to gradually increase the start basal insulin and then gradually increase and increase and increase until the requirement is low enough for you to stop the pump. That's what I heard people are doing. Do you have other idea?
Yeah, so without a doubt, we're seeing this happening again
Yeah.
and again, where we have using 8 units, 10, 12 units per hour just to get the patient out of the acidosis as well. Sometimes the glucose does respond well, but the acidosis seems to be persistent, and the ketonemia also persists, which requires us to keep using the high rates of insulin and then having to juggle the sugars, which may come
Oh,
down to low range. So in the end, maybe another opinion about when you
oh,
introduce these dextrose infusions, and sometimes you require higher than usual, sometimes dextrose 10, sometimes dextrose 20, because you still need the insulin
okay.
for the
Okay.
acidosis. Yeah.
My experience, sorry, for the first question, I was referring to a person who are on IV insulin, whose DKA has resolved and they're just waiting to transition to subcut. But
Yes.
if let's say the DKA takes time to resolve, my experience is that there are usually ongoing disease process happening. It's just undiagnosed disease process like an infection that is not adequately treated. Usually this would require a relook at the diagnosis or the investigation. You might want to get help because my experience is that I don't have a data to back me on this, but I've seen a number of these people, they have a high mortality rate.
Yeah.
So when their DKA doesn't resolve within that stipulated time, because either you miss something or their underlying disease process is so severe that the treatment that we provide is not effective enough to modify the stress level. Unfortunately, I don't have a good answer to this question. I would say as long as maybe if let's say if I would need to use D10, D20, I certainly have used them before. We try to use them using a central line, but I also want to remind that there are also other life saving procedures for DKA, for example, like mechanical ventilation or hemodialysis that you might want to consider rather than, continue to pump glucose and glucose and glucose and the ketone continue to climb up and not knowing what to do next, right? So these are the time when you want to really get help from your nephrologist and your ICU colleagues.
Yeah. Yeah, so really some practical things like making sure you have really good access lines that your insulin goes in. Sometimes it's the problem of not getting that insulin properly, and hydration's not good enough. So all the basic principles still have to be done right, from the very beginning. And you did mention about the use of subcut basal, and we noticed that nowadays we're doing it almost routinely, Lokman, because
I know.
because the type of patient that's coming for DKA is actually not the lean type 1 who gets out of DKA very quickly, but in fact it's the opposite. It's the obese type 2 with lots of intercurrent problems causing the insulin resistance, and you end up using high IV insulin, and you end up having to give that subcute NPH twice a day at mega doses to get them out.
Yep.
That is the type of thing we're seeing now. We have another question here, and it congratulates you, Dr. Wong, congratulates Dr. Lukman for the brilliant talk. And he says, playing the devil's advocate here, in which situation or patient group that you would not initiate SGLT2 inhibitors? So this is not probably related to DKA. Among type 2 with heart failure. So it's a very broad question, maybe not
Okay.
the exact topic today, but nevertheless.
I'm going to speak on from my own practice. You call it pattern or bias or you call it lah. I tend not to start SGLT2 inhibitors in the very old people who cannot look after their hygiene. I do feel that we'll always talk about DKA, but I do feel that in some people that genitourinary infection can be bad, especially if they have poor hygiene, they are on diapers. And this brings us to an important consideration: do you start them post stroke? No? Because like macam those cardiovascular disease, but if they are on diapers, I might want to like really be careful for this patient. If they have heart failure, I think it's hard not to start actually, because the data is so clear. You can make an argument for stroke because when you look at the that subgroup analysis, the risk of the benefit for stroke is not that much pronounced, but for heart failure it's hard to make an argument against not using SGLT2 inhibitor because because it's very safe. It doesn't cause electrolyte imbalance. Short of that genitourinary tract infection, because most patients with heart failure they are on loop diuretics anyway, and they pee all the time anyway. So it's hard to make that argument against lah. But I would my practice, I would try not to use in those who are very old. But otherwise, I think the standard contraindication applies. Yeah, I just want to highlight that the recent EASD guideline has brought down the EGFR cutoff point to 20.
Yes.
Yeah, for initiation of a SGLT2 inhibitor. But if you initiate before it went down to 20, you can still continue all the way
Until dialysis.
until dialysis. Yeah.
Yeah. So yeah, I reckon, looking at SGLT2, the future would look like, almost a half or a third of people would really benefit from SGLT2 inhibitor if they have type 2 diabetes. For proteinuria, and then definitely if they have heart failure, isn't it? If they're diabetic or even non-diabetic.
I was thinking this morning, like SGLT2 inhibitor nowadays are pretty much like penicillin. We use it to pretty much everyone.
Penicillin. Oh, you still almost like metformin.
No, at least metformin used for diabetes and PCOS only. Like penicillin used for all types of infection. Like basically anyone.
Non-diabetes, yeah.
Non-diabetes, right?
Yeah. So we're fortunate. We this year we sort of important because SGLT2 inhibitors are actually now available in primary care of MOH. Yeah, and the second SGLT2 inhibitor, dapagliflozin, has got into the MOH formulary. But budget is still tight, so we're really looking how to actually make sure that the right medication can be prescribed.
Well done for fighting for the budget. That was a big step.
Yeah, well, we don't know yet whether we'll get a specific budget for it. Anyway, we should go away from SGLT2s. Dr. Luman, we don't have much information about type 1, yeah, but do you feel that type 1 diabetes management is improving in the country? Like DKA rates are coming down and we're getting better? I'm a bit concerned because as endocrinologists, we're almost directly responsible for the outcomes of type 1 diabetes.
I do not have the exact number on DKA rates. Recently, I think Prof. Yazid published data on the glycemic control for people with type 1 diabetes. I think the average HbA1c is still somewhere around 8. Not very much different from the type 2,
Right.
in terms of the average HbA1c. But I can certainly say that I don't know whether these people are. I'm like a magnet to these people. I do certainly say that there are more interest now in type 1 diabetes. I can say that from among the trainees, there are more interest on learning how to manage type 1 properly, how to do carbohydrate counting, how to do sensor pumps. I would imagine those new devices, maybe they get encouragement by the manufacturers, but even for old treatment like carbohydrate counting, exercise, sick days, I think there are an increased interest in this topic. I do feel that the type 1 community in Malaysia is relatively underserved.
Yes.
When it comes to their treatment, their healthcare. So I do feel that it gives me a personal like motivation to try to help them in that sense. And this is the same thing I told my nurse also, like why we look after this patient so much, because they need help.
Yeah, thank you for that, because I think ending on that note is really important. As much as most of us here, I think internal medicine physicians as well as endos and rest are managing a lot of type 2, but the type 1s in the country, we really need to ensure that they get the most up-to-date and current care and the best outcomes as they go into adulthood and live longer and survive longer. All right, so we've come to the end. It's already almost 4, and I think we've had a good session, an update on the different issues relating to DKA. Thank you, Dr. Lokman, for really reviewing the literature and updating us. And it actually would spark a lot of interest in the rest to read around the area. With that, I'd also like to thank the audience and also our coordinators from Hospital Taiping as well to coordinate today's webinar. So thank you everybody for joining us, and would remind you to please keep on attending the series for the month of October with very interesting endocrine topics. So with that, I'll just say Assalamualaikum and good day. Thank you.
Okay,
Thank you so much, Dr. Thank you, Dr. Lukman. Thank you, everyone. Please scan your QR codes for CPD points, and please join us next week because we have another interesting topic all about osteoporosis by more experienced speakers. Thank you.
Okay, Abhinash.
Thank you, Dr. Zanaria.
Okay, so I can go out now, yeah?
Yes, you can.
Thank you so much. Bye-bye.
Bye, Dato'.